So I couldn't resist the temptation to show you this picture, although I said in New York for a couple of weeks ago that that would be the last time you saw the gluten man on stage. This was given to me from Peter Gibson after a stay in Melbourne for some few years ago, and I'm going to come back to the studies that we have done together. So my intention now is to talk about celiac disease and the basic immunology of celiac disease. I'm going to talk about experimental diagnosis of celiac disease. I'm going to talk about how to distinguish non-celiac gluten sensitivity versus celiac disease in a couple of ways, and we're going to end up with a possible application of what we have been working with, which I think will be quite exciting. So, yes. I've already mentioned these two typical clinical scenarios. This is the celiac disease, as you, most of you are quite familiar with, but we're going to go a little bit into the details. A small intestinal enteropathy, typically also with antibodies to tissue transglutaminase and to deamidated gliadin peptides. You can, at least in children and maybe soon also in adults, use serology as a proxy for diagnosis, but we're not going to touch upon that aspect today. And then you have non-celiac gluten sensitivity, which I'm certain that many of you have seen these individuals. Maybe we can call them patients. Some may be patients, some may feel better when they drop out gluten in their food. And the question remains, what kind of condition is this? In our 2012 paper, we said it's clinically quite like celiac disease, but it's not. There's no enteropathy, and serology is negative. Just to remind you that the enteropathy and the serology in celiac disease is dependent on gluten intake. So this is a little bit of a problem when the patient already is on a gluten-free diet, and that will also be topic of my talk. As has been said, I've had the opportunity and the pleasure of working with celiac disease for many years. Actually started late in the 1980s together with Ludwig Solid. He defined the HLA association in the disease. We summarized some of our findings in a small review in 2009, and this cartoon is from that review. We know that gluten is chopped up by enzymes within the gut lumen. There is some enzymatic degradation also in the brush border. Gluten transverses the epithelial layer. It meets an enzyme here, transglutaminase, which is present in all of us. It does have completely different, it's not there to digest gluten, but that's a side effect of the enzyme. It renders these yellowish gluten peptides to something which is red, so it's a chemical modification of the gluten. This is presented by antigen presenting cell within the lamina propria, and it is correct that I also had the pleasure of showing gluten-specific T cells, which was reported early in the 1990s, and with which several other groups have been working, not the least the Dutch group from Frits Koning, but also here in UK, Professor Ciclitera. There are several who have done the same things, showing that this is in fact the single difference between a celiac and a non-celiac. So these aspects are probably similar in all of us. This is the single thing which is really different in celiacs and non-celiacs. And just to step a little bit also to introduce to a very important technical aspects which you're going to hear more about in my talk. We can stain these cells with a construct. We term them HLA tetramers. It's actually a staining method for gluten-specific T cells, the T cells which are relevant for celiac disease. So if a celiac eats gluten, it's deamidated, it is recognized by T cells. These T cells give help to plasma cells. In the past, we thought that these would give rise to antibodies. Well, they do. They are producing antibodies to transglutaminase and to deamidated proteins, but we had the idea that these antibodies would spill over into circulation and could be detected in a serology test. That is not true. The antibodies that we find in this circulation are derived from somewhere else. We don't know exactly where. Maybe bone marrow, maybe lymph nodes, but just, well, that's a sidestep. We know a lot about this disease. We know how gluten is chopped up by digestive enzymes. We know that transglutaminase comes in sniffing on these glutamines and changing them so that the Qs are transformed to E's. E's is glutamic acid. We know that there are big fragments in gluten, and we know that within a certain fragment you can find a lot of T cell epitopes, 6 different epitopes, so this is a strong antigen for those who have the relevant T cells, and we know that these peptides are presented by DQ2 and DQ8. And they are presented by these HLA molecules because they fit so well. So if you don't have these HLA molecules, you cannot present them and you cannot have celiac disease. So things are coming very nicely together. As a consequence of the disease, you are all aware though that there are many clinical aspects. Neuroceliac disease, you're going to hear more about this. Thyroid disorders, diabetes, osteoporosis, cancer, malabsorption, etc. Although the vast majority of celiacs, they are very healthy, at least when they are on a gluten-free diet. So celiac disease is, bluntly said, the immunological disease that we know of in most detail. There is no other disease which is understood at this level. We know it's an adaptive immunology, so adaptive means the immune system has learned. It's the T cell and the B cell system. It's dependent on gluten intake. It's strongly associated to DQ2 and DQ8, which are also present in at a big majority or a big group in the Caucasoid population. Very much is understood. Restricted T cell receptor usage, long-lived T cells. When I started doing research in the mid-1980s, we collected some celiacs. We froze down the cells, Ludwig and I. I met the same patients last year for a new endoscopy, new blood test, and we found exactly the same T cell, so some decades afterwards. So it's a long-lived memory adaptive T cell response. It's a restricted B cell receptor usage, well-defined gluten peptides, but little is known why this develops. And I know that Professor Danagar will talk to you later about what triggers the disease. So let's first go into application of our knowledge. You heard about the HLA tetramers. You know we are dedicated to improve diagnosis and understand the disease because of our own interest and because of the benefit of the patients. So now I'm going to talk about experimental diagnosis of celiac disease. It's not accepted yet, it's not out there yet, but yes, we are working to commercialize this, of course. So flow cytometry, most of you may have heard about it. You take a sample of cells from blood, from a biopsy, you chop them up, you can run them in a machine, you can divide them, you can separate them, you can pick out the lymphocytes. So this is typically from a blood sample, 10.5% lymphocytes. You can take away singlet cells. You can go on and you can do another separation, where you exclude the monocyte, the macrophages, the granulocytes, etc. You can take the next step with the HLA tetramer, next staining procedure, and you can isolate this 1.8% of the cells. So now these are 1.8 of these starting populations. So we are talking about few cells, but they can be definitely be recognized in a flow cytometry if you know the technique. And we can use this to in fact, oops, sorry about that. We can show that these are memory cells. We can play around with these cells in vitro. So we use this technology which has been around, and Jason Tydin also mentioned that they have tetramers in Australia. There are not many people who have this technology, but we have it. We have had it since the early 2000s, but now during the last years we have really used it a lot for clinical purposes. This publication came out last summer from my PhD student, Vika Saina, where we looked at what happens with celiacs if they eat gluten for 2 weeks. So a defined gluten amount, pure gluten, vital gluten. There is no FODMAP. It's the same gluten that we have used in the later part of my talk. And what happens if you give a person with celiac disease gluten for 2 weeks? Well, serology is not of any use. They do not relapse. You cannot take a serology test and prove that they have eaten gluten. So this is the cutoff, local cutoff. You see these are very small values. And untreated, most untreated celiacs, they would have levels way up here, way up here. So 2 weeks serology, no good. You can take a biopsy and you can take a look at the villus height, crypt depth axis. And yes, treated celiacs in our society, they have long, fine villi. After 2 weeks with gluten, it does go down, but it's not very impressive, and it's not the best diagnostic method to prove celiac disease. So we used our tetramers. We investigated mobilization of tetramer positive cells from baseline to day 6, and this is a better signal. So going from 3-4 cells per million, so we're talking about small numbers here, difficult technology, it increases to typically 50 per million. But this is a definite signal, so almost all celiacs respond. There are 3 celiacs who do not respond, but all patients with definite celiac disease, they tend to respond in this 3-day challenge with gluten. And you can also do flow cytometry identification, activation of cells. Now we're talking about really distinguishing activation of cells. Those who do not stain with the tetramers, they are not activated, so this is a completely disease-specific process. But so far I'm talking about gluten challenge. But it can also be used without any gluten challenge. This paper was our first. This identifier shows you the number of cells in circulation in control patients, in untreated celiacs, and in treated celiacs. And as you may be able to see, a control DQ2 positive person, they do not have these cells in their blood. They are very, very, very few. And when we try to isolate these cells, they don't recognize gluten. So they are just, it's as low as you can possibly get. Whereas an untreated celiac, they have in abundant numbers, and also a treated celiac. As I told you, it's a memory response. They are around. So although the villi improves, the T-cell response is still there. Vikas have taken this further. Again, the same HLA tetramer technology, but now in bigger groups, gluten sensitive, meaning persons who avoid gluten but do not have celiac disease versus treated celiac disease, 62 versus 19, and you can see the cutoff. all the treated celiacs, they have these cells in their blood, and gluten sensitive without celiac disease, they do not. You can also take a look at real control patients. These were just taken from hospital staff, DQ2 positive versus untreated celiacs. All untreated celiacs have these cells. Controls, they do not have it. Some of you with sharp eyes may see some here. And I can tell you they were taken to the endoscopy room and they turned out to have celiac disease. So this is a flow cytometry based not serology, but blood test for celiac disease in the absence of gluten exposure. Maybe it can be commercialized. Of course, we are discussing that. Then what about the other aspect of gluten-related conditions, the non-celiac gluten sensitivity, which you see in all newspapers, all the celebrities, etc., etc. There are two major hypotheses around. One is that non-celiac gluten sensitivity is caused by a more or less specific but innate immune response. So innate immune response, which means it's the kind of immune system that recognizes bacteria, for instance, other danger models. It's not adaptive, so it's not learning. It's a fast response. So it should be an innate immune reaction to proteins in gluten, something in the cereal. Maybe it's gluten, maybe it's something similar. Amylase trypsin inhibitor has been mentioned. Maybe it is. Versus the other possible explanation, and that is that it isn't the gluten, it's the FODMAPs, it's the carbohydrates, which are also present. And these are our main sources of carbohydrates, fermentable, poorly digestible constituents of food. And as you can see, bread is here, and bread is a very important source of FODMAPs in our diet. So if you cut out bread, you will also effectively reduce your FODMAP intake. And then the question remains, which of these are correct? I used to think it was this. This earned me the designation the gluten man, but we'll see. So why bother at all with non-celiac gluten sensitivity? Why care about these individuals? Well, it is known as non-celiac wheat sensitivity, and also it has been given the designation PVAG, so people who avoid gluten. Most of these individuals that we see in our healthcare system are self-instituted gluten-free diet, and they do it quite well. They come to us and they ask, do I have celiac disease? I think that's a fair question to ask. They also, in some cases, they ask, do I have to stay on a gluten-free diet? And in our country, we are the richest country in the world, so we reimburse gluten-free diet for celiacs, 200 euros per month. And also non-celiacs can have it. It's a major problem for a doctor to sort out who shall have those money, of course. I'm not going to go into details. We've been working in this since 2008, 5. So we checked 130 persons that were gluten-free. We found 35 who had DQ2. We found 3 of them to have celiac disease with a 3-day gluten challenge test. So that's the first message. Of gluten-free persons on their own, very few have celiac disease. And we found they were not crazy, so no sign of psychosomatic disorder, and we did some immunobiology. What we also did, because of this reimbursement problem or aspect, we have done systematic challenge with bread in these cases. It's not ideal, but take a look at the data. These are gluten-free persons coming to us. Before they eat bread, they have very low symptoms, so they are more or less completely healed from their abdominal symptoms. after they eat bread for 3 days and they report their symptoms go up. There's another group here which I labeled as they probably couldn't have non-celiac gluten sensitivity. They had more symptoms before eating bread and it didn't really increase. So this is the typical scenario. People come to us and say, well, my life has changed, I've stopped with the bread, but is it gluten? Well, if you give them bread, they have symptoms, but it's not ideal, it's not blinded, it's not, we give them gluten and we give them FODMAP altogether. So how to distinguish? So with Peter, we developed another vehicle. This is a prototype, a good-looking muesli bar. You can spike in, it's a snack. You can spike in FODMAP and you can spike in gluten without FODMAP, and nobody can tell the difference. When we produce it, this was the prototype, but in large-scale preparation, it looks more like this. So whenever persons come to us and they are having a gluten challenge, oh, can't I eat all the good things? No, you can only eat this one. But it's quite nice, and it's standardized. So this gluten bar typically contains 5.6 grams of gluten, which is what we calculated that to be the amount of 4 slices of bread, and it can contain 2 grams of fructose, which also equals 4 slices of bread. And what happens if you give this in a blinded manner? 3 different bars, 59 with self-reported gluten sensitivity. This is the outcome. Fructose gave the symptoms. There's absolutely no sign of on a group level that gluten gives any symptoms. If you look at individual courses, there are some individuals with highest response after gluten challenge. So some few have a response. But then the problem comes as a clinician, how to evaluate this. When there are more who have the highest response after placebo challenge, there's even the positive signal is for fructose. There's lowest on placebo challenge, and I can tell you that there is a group with highest response after gluten challenge, but there's a bigger group with less response after gluten challenge, meaning that this is senseless. This is the blinded challenge, food challenge stuff. It doesn't work. So finally, I'll propose how these things come together, and I'm going to propose to you a test which has been looked at together with Bob Anderson and Jason Tydin and Vika Sana and the rest of the group. It was presented in the daily meeting headed by Professor Makaria in 2017, 2 posters. And these are the data. This is a single snack, a single muesli bar with gluten. There are 2 groups of patients here. There's a non-celiac gluten sensitivity patients, those who were on a gluten-free diet, because in the absence of celiac disease, and there are celiacs here. The celiacs, they respond with an IL-2 response after 4 hours, which is very clear. So all the celiacs, they respond with a cytokine signature after 4 hours. It drops down after 6 hours. IL-2 comes up, definitely. IL-8 and IL-10 also comes up in the celiacs, and the non-celiac gluten sensitivity person are here. Nothing happens, even though they think they are gluten sensitive, even though gluten has been claimed to have innate immune response activity. 14-day gluten challenge gives symptoms, very slow serological response. It does give you a mucosal response and immune response, and it does give you IL-2, IL-8, and IL-10. 7-day gluten challenge, none of the above. Symptoms after FODMAP challenge, not gluten challenge, but I should, of respect for the patients, say that most of them are still on a strict gluten-free diet. So they still continue their gluten-free diet. And they respond when we grow the bread. But for those who have followed this field, where did the innate response to gluten disappear? Lastly, thanks to my co-authors at the University of Oslo, at Monash University, Jane Muir, or especially thanks to Ludvig Solid, with whom I have worked since mid-1980s, Imu Sante, Bob Anderson, Leslie Williams, John Juris, and Gautam Goel, and for funding bodies. And thank you very much.